We want to welcome you, as I said, to our virtual presentation named Interventions for Cancer Treatment Side Effects. We're very blessed today to have three wonderful presenters with us who are going to share their knowledge and expertise. We'll start with Nicholas, who is our first presenter for today. So I'm very happy to have Nicholas here with us today. Nicholas works at Ivy Rehab Physical Therapy in Danbury, and Nicholas has a doctorate in physical therapy and a Bachelor of Science in Kinesiology from Penn State University. He specializes in treating patients with chronic pain, neurological, cardiopulmonary, oncology, and vestibular orders. He provides evidence-based orthopedic manual therapies for spine, upper extremities, lower extremities, post-surgical, as well as sports medicine rehabilitation. Each patient that Nicholas treats will be empowered with both the knowledge of the root cause of impairment and the tools to overcome it or to cope with it better. Outside of the clinic, Nicholas loves spending time with his wife and his two children. So with that, I'm going to welcome Nicholas and thank him again so much for joining us here today. Let me just find you here. There you are. And you are spotlighted. So welcome, Nicholas.
Thank you. Thank you so much, and Place and Kate, for having me join this talk. And can you guys see the screen, by the way?
I can.
Okay. All right. So I'm going to spend some time today speaking to you all about how inflammation is affects, post treatments in terms of chemotherapy, radiation therapies, and other forms of therapies that are available currently. And the first and most important thing is what we're going to get out of this. My talk is basically, by the end of this presentation, I really would like to hope that you learn about certain common symptoms that are associated with the cancer diagnosis, which most of you may know of, most of you may not know of. And to identify, what problems can be successfully treated by a trained physical therapist and how we can provide interventions. And then also importantly to understand about inflammation and what steps obviously you can take to combat these symptoms. And at the end, just a quick brief overview of three simple balance activities that I usually give to my patients who sometimes do have neuropathies and loss of sensation from either the medicines, the chemo, the radiation, and also from the muscle atrophy that occurs from the side effects of chemotherapy. So basically right now, currently in our atmosphere or stratosphere of medicine, these are the treatments for cancer, generally speaking now. There's, obviously there's surgery for, mastectomies, there's radiation therapies, there are various forms of chemotherapies and different kinds of drugs that are used for both hormonal therapy, immunotherapies. There are also bone marrow transplant therapies, and gene and vaccine therapy are now currently experimental. They're pretty aggressive and progressive and are very unique. Right now, the studies are kind of low in terms of how many patients are going to vaccine and gene therapy, but it seems to be shifting in that there is a very distinct correlation between genetics and finding a genetic composition with cancer and the type of cancer that emits from it. Basically, oncology rehab in general, during therapy that I provide for patients and that we provide for patients as PT, there's proven that chemotherapies can provide benefits in terms of increasing the circulation and increasing the targeted tissues that have been biopsied or are cancerous. And the best form of therapy that we can provide as therapists is to stay active, to get muscle and blood flowing to that area to promote a form of healing. Because blood flow and getting circulation to that area is the best form to help improve and restore wellness and healing to that tissue. Recent findings, we have found that exercise initiated at least 1 week prior and also continuing during the course of chemotherapy and or radiation therapy. Fatigue ratings have been improved. Now, basically what that means, a 5 out of 7 functional measure. We use different scores here, which we use, it's called a Borg scale score. And a Borg scale score, typically it tests how much exertion your body can withstand with certain different levels of exercises. So let's say you were walking, let's say you were cycling, you were walking a certain type of mile per hour. That's a certain amount of force that exerts onto your body. And we measure that, how your heart rate changes, how your breathing rate changes, how your blood pressure changes, and how much exertion you're exposing. So we have found that initiating that 1 week prior to chemo, radiation, and even continuing, the ratings jump up to a better score, a better outcome, rather than not. And that's from the Journal of Strength and Conditioning. Basically, this is a slide that just shows a summary of common problems with treatment for cancer as we know right now. The most important one is fatigue that I've noticed. Fatigue is a huge factor, particularly because unfortunately the chemo and the radiation, it does not care about healthy tissue. It goes and it attacks even healthy tissue. And when you attack healthy tissue, those are really rich in nutrients, and it affects how, we breathe, we move, they affect muscles, they affect the lymphatic system, they affect some of the breathing muscles that are helpful, which again, all are correlated to fatigue. So endurance training, cardio aerobic conditioning is very important, and muscular strength training is important. We have found that there's bone loss from some of the different kinds of chemotherapies and radiation therapies, muscle loss. Neuropathies, not as pronounced, but they do happen. They are common. And neuropathies, just briefly, it's a loss of sensation. It could be very specific, or it can be very gross, depending on where the chemo and the radiation has been put. Most of the time, it's in the lower feet, but there have been times when it does affect the neck, the back, and some of the limbs as well. We have seen weight gain because there's been an increase in appetite, and also the swelling. So the body swells to help, and that's a normal course of inflammation to help heal. There have been postural changes because of weight gain and muscle loss and bone loss. So rather than having a very nice erect spine, unfortunately, with gravity that wants to pull us down, we do see a shift in how our body is malaligned from all of this. And there is a high risk of infection. There is a decrease in range of motion, which again, it's all correlated to the loss of muscle and the spine integrity. There is also lymphedema. The lymphatic system is involved, sometimes, not all the time, but sometimes when they do remove a mass, part of the lymph nodes are removed and the lymphatic system swells. And then, unfortunately, there is this brain fog, which I put it in quotations, and basically, there is a time when all of this fatigue and the stress of all of this affects how we coordinate, how we focus. So the best thing, again, is the cardiovascular conditioning, because aerobic exercise has shown to increase blood flow to the brain and actually help reduce some of this brain fog. One of the things I wanted to bring back again is that we focus, at least in my treatment, when I'm dealing with patients, oncology patients, I do work on their fatigue and the muscular loss and the posture and alignment. Now, what really causes this fatigue in the body from chemo and radiation therapy? The direct effect is of the tumor and of the microvascular bed. You have this mass that's in your body, and you have capillaries that are in the body that unfortunately aren't working at the 100% that they used to. and they don't open and shut when oxygen is needed by these muscles. So think of it's like basically a plug that's not appropriately opening and closing for allowing blood to enter into that body or that muscle part. Other comorbidities that can create this fatigue is anemia, blood loss, or iron deficiency. That could be something that was already pre-existing prior to the chemo, but there has been studies to show that there are issues like anemia that can create some of this fatigue as well. Pain and deconditioning. So the pain and deconditioning, again, is all correlated to you have muscle loss, you have strength loss. So the body is not at 100% capacity. So unfortunately, what happens when you have muscle loss, the joints of the parts of where the muscles attach to, unfortunately, get all of that stress. So that's where the pain comes in. And the deconditioning comes in because you don't have the muscular mass to help you locomote and negotiate things that you need to do. And then, yes, there are psychosocial factors with all of this, the stress, the anxiety, the depression that can occur from this, and family that gets involved. I don't touch on that very much. I do talk about it. And if there are issues that come up, there are definitely other, professionals that I seek to make sure who have the experience to work with patients who are going through this, but it definitely does affect the overall wellness of a person. And also sleep. Sleep is also affected by all of this, and that can create an issue to help your body from healing. And not having the adequate sleep affects the integrity of how these tissues heal. So when that happens, I do get intervention. I help, and I have I use psychiatrists and psychologists that can help patients, possibly with some mindfulness, some meditation. There are cognitive behavioral therapies that I teach patients of and be aware of, but I do definitely refer out if that happens. So here's a bit of criteria that we use to just see whether or not you actually have these symptoms of chronic related fatigue. And actually, you would only need a minimum of 6 of these for 2 weeks. So it can be any combination of any of these symptoms that could last for 2 weeks. The most that I have seen that is very common, at least that patients that I treat, are functional limitations in daily activities. I'm having a hard time, loading a load of laundry. I'm having a difficult time walking a quarter of a mile. I'm having a really tough time focusing while I'm driving or paying attention. My emotional distress is also very important. So those are the top issues that I have seen, especially with fatigue and deconditioning that occur. And again, sleep is very big. It's very underrated, but it is a very big issue. And a lot of times, I would say 70% of the time, a lot of my patients are not getting a full night of sleep. And a full night's sleep is very different from many people. It could be anywhere from 4 hours to 6 hours, but I usually typically think that 6 hours of sleep, of non-disturbed sleep, is a good amount of time. So again, the fatigue factor. 90% of patients with cancer, they report fatigue, and about 75% report fatigue lasting for months, 3 to 4 months, or even actually 5 to 6 years post-treatment. Now, those percentages can be skewed because there are a lot of factors that get involved with this. Were these patients active before they received chemo? Were you active while you were receiving chemo? Did you decide to become active after chemo? So these percentages are not like set in stone, but they can be a little tricky because again, if you weren't active or you were active, it changes the numbers. From my experience, if you were an active person prior to the chemo, these numbers aren't as high. The recovery actually is better. You may not feel as much fatigue, but it's a drastic change in how your effort and what effort you put into the exercise. So I really try to push for exercise for patients with with chemo and radiation and cancer because it helps. And if they were very sedentary prior to, I really tried to be gentle and educate to them how important it is to exercise. A lot of the times, my patients are like, I'm just really happy to be alive. You know, I have children at home. I have a husband at home. I don't want to bother with exercise. I'm just happy to be alive. I have friends that have a worse situation that I have. So these are things that get explained to me. And I try to explain to them, you know, what the long-term effects are and the side effects are if you do not exercise. And simply put, it is this continuous feeling of exhaustion and not relieved by rest. This fatigue is not just, okay, it's just about muscles and bones. It's a multifactorial right now, and because cancer has been studied very much. And a lot of the research now has changed to, instead of being like one specific thing, now it's a dynamic approach. It's multidimensional. What does that mean? It could be a spiritual. How you perceive cancer is what I mean by spiritual. How do you feel about the idea of having cancer in your system? You know, that's a huge thing. Your religious beliefs or your cultural values plays a big part of it. The cognitive approach is more about its concentration. It is about slight memory loss and problem solving. And again, I don't like the word chemo brain, but that's the nomenclature of what they use. But there is some of this that is happening, and this mental fatigue is occurring. And again, with exercise and with breathing and just getting blood flow into the brain, these memory issues and these problem solving can be diminished. And obviously it brings up to the point of physical. You know, the cardiovascular system is your heart, and your lungs is your aerobic system. And those two are very important to get blood to where they need to go. And the oxygen has to get to the areas where they need to go. So those plugs can open up and allow healing to occur. So with therapy, endurance is key. Building up your endurance is key. Doing it appropriately and not, you know, enforcing it strongly is also key. So pacing is very important. I talk to a lot of my patients about pacing. It's very important to pace and not overexert too early on. And our treatment, my treatment, there's no cookbook. There's no recipe that I have that therapists use across the board. It's very unique to the individual, but the foundation is the same, that we want to encourage staying on track. And again, particularly again, if patients were coming in and they were very sedentary and exercise is a completely new idea to them, journaling is very important in terms of documenting what they've done, in terms of, let's say I went to a walk to the grocery store, or I can't even get down to get my mail. We start baby steps, and I ask my patients to journal them. And how many days a week do they walk, and document a variable, either time or distance. So I usually ask them, well, if you know that you can walk 5 minutes, I would encourage you to walk 5 minutes for the first week, 2 to 3 times a week. And then we can add more time, usually typically 2 to 3 minutes a week for the course of 2 months, 3 months. You could also use a variable of distance, you know, so either one can work. So it all depends on building up your aerobic tolerance because you want to increase this oxygen level, and staying on track by recording it can help you understand it. And in time, you can increase your aerobic tolerance. So, you know, 3 to 5 days a week, again, for someone who doesn't work out or someone who does not exercise regularly, that can be daunting. So I compromise and I work with the patient depending on what the uniqueness is. And I tell them to start at least twice a week, see how you do there. Work up to 3 times a week, see how you do there. And, you know, this is a course of a lifetime. This is not just for the course of therapy. So I tell them this is a marathon. This is not a sprint. You know, this is something that takes time. And then there are times when I have to tell patients to pace and rein it in because they may be overdoing. And then they're overly fatigued, and then they're falling asleep, and they're lying in bed and they're not able to function. So pacing is also important as well too, so that you can be with your family, be with your grandchildren, be with your children, be able to live and not have really fatigue and being tired. So we have noticed that, in therapy and in studies, a lot of the focus of the therapy is on arms and legs because those are the bigger muscle groups. The arms, interestingly enough, moving your arms and doing an exercise with your arms, you have to expend a lot more energy because the mass of the body of those structures are smaller. Whereas our legs are a lot thicker because they're carrying our body weight. So the amount of effort it takes for us to move with our arms, it's going to increase our heart rate, increase our respiratory rate, because we're trying to move our body with smaller muscles and smaller mass, smaller bone structures, whereas compared to the lower body. So we try to work at a 50 to 70% of your maximum heart rate. So your maximum heart rate, normal heart rate is 60 to 100 beats per minute. And you can measure it by taking your pulse. You can measure it by using a pulse oximeter, which is what we use here in the clinic. But usually, typically, normal resting heart rate is anywhere between 60 to 100 beats per minute. And then when you exercise, it is common and normal that your heart rate jumps up about 15 beats to 20 beats per minute. So you just have to be careful when you start going up 25 to 30 beats per minute, but it's still okay. So sometimes patients come in like, wow, my heart rate is already at 75. Am I okay? I'm like, yes, that's fine. You're in the norm. And sometimes medications do have that side effect where they increase your heart rate and your respiratory rate. Pain is another primary, aside from fatigue, with patients who are receiving chemo and radiation therapy. Pain to the visceral organs, pancreas, liver, gallbladder, sometimes are affected. Again, unfortunately, when you get chemo and radiation, they don't care about how healthy the tissue is. They go and they unfortunately do take some healthy tissue. So that healthy tissue does get affected by the chemo radiation. Neuropathic is another big one. Neuropathic is basically your nervous system that has a loss of sensation into the body, and it's caused by irritation of your nerve endings. And again, most of the time I've seen this has been in the lower part of the foot and underneath your foot. And if you're not sure if you have neuropathic pain, what I advise a lot of patients to do is check with their oncologist, or they can check with their oncologist first, obviously. They can get what's called monofilament tested, which is basically a specific type of test that tests the sensation of your feet, and it determines how much loss of sensation you do have. And that could be temperature, it could be from a pinprick to a dull kind of movement, but this is a specific test that diagnoses whether you do have a neuropathy or not. And skeletal, musculoskeletal conditions occur because, again, we talked about loss of muscle, loss of the spine integrity, and the fact that you're not moving as much as you were prior to. Sometimes, again, post-mastectomy, there's reconstructive surgery, there's grafting, there's plastic surgery. So even after major reconstructive surgery, I encourage a lot of patients to take and go through physical therapy to increase the elasticity of the tissue and the range of motion that gets affected by it. So pain science and physical therapy, this slide basically is just stating that, there are new treatment options to prevent a type of central sensitization during oncology treatment. What does that mean? So you want to take the issue and center it to one issue rather than making it a gross issue. And what methods do we use for that? So, for example, I use a lot of visualization when I work with my patients. So body image is key. And I teach patients, this is where your posture should be, and this is how it should be aligned. And the visual aspect is really important because they actually see their bodies malaligned, and they don't realize how malaligned they are, or they don't realize how much range of motion they're lacking, or they don't realize how much compensation of movement they have created for that loss of range of motion. So I use body image as my main form of treatment to help. And with that image, patients can use the right techniques and the muscle activation, which again, nerves fire to get those muscles activated. So again, I use mostly the body imaging to help. And the pain can be reduced by just basically teaching patients how to get in the proper posture to take pressure off certain joints, and how this can create tension or spasms, or headaches, or muscle spasm in your neck or in your back, and muscle pulling. So just changing the alignment, or how your feet are, how you're walking, how you're moving, definitely can make a significant impact on how you're feeling in that pain cycle. I'm not going to spend too much time on lymphedema, but they are performed by physical therapists and occupational therapists who are certified in lymphedema. They are called lymphedema specialists. And lymphedema specialists are amazing to help patients with improving the lymphatic drainage of the body. And they wrap certain parts of the body to help lymphatic flow into the body, so that it reduces some of the swelling that occurs from the lymph nodes that have been inflamed post chemo radiation, and also certain types of surgical procedures. Therapists do provide gentle lymphatic massage following the lymphatic system, whether it be your lower body or your upper body. We use our hands with that. We can wrap, like I was talking about patients, we could wrap patients with they're called compression wraps. Obviously, activity and exercise is very important. And myofascial release is also important. Myofascial release is basically, you have different skin layers of tissue, and again, it's all hands-on work where we work through the different layers of tissue to kind of release and reduce some of the irritation that's in the body. And when you release those tight restrictions, you're allowing blood to flow into that area and releasing and relaxing some of the spasming and the muscle strain that occur in that part of the body. So therapy can help, physical therapy can help. We've been trying to work with many different various oncologists in the area to promote physical therapy because, there is this nomenclature that some therapists or some oncologists try not to push therapy, but they've come around, and we really appreciate that now physical therapy does help. Exercise helps, occupational therapy helps, lymphedema specialists and therapies all help directly to that specific problem. Right now, unfortunately, there is no evidence-based intervention for peripheral neuropathy caused by chemotherapy toxicity. So right now, they're still trying to find out through gene therapy, through plasmid-enriched type therapies to see if there's something that we can do. There are certain modalities of therapies out there, and I think one of them is called neurogenics. Neurogenics has been around for quite some time, and they use a system where they actually work into the deep nerve tissues to actually help increase blood flow to reduce some of the nerve pain. But what we do as therapists is, again, I realign patients and how they move and how they walk, which ultimately can help them breathe and help them thrive a little bit better, and help them reduce the muscle loss, the fatigue, and also help with, endurance. Quick notes about inflammation. There are two different kinds of inflammation. There's chronic and acute. In a nutshell, acute inflammation is something that's very quick, which happens within 2 to 3 days. And then chronic is something that occurs mostly, weeks or months that can occur. So this is just a really good slide that describes how your body fights inflammation. So let's say you step on a thumbtack. Thumbtack is a laceration, there's a puncture wound, blood will flow into that area. You'll have swelling, you'll have redness, you'll have different kinds of ways the body will try to help heal itself, and your immune system has to be on par to help fight it. So unfortunately, with chemotherapies and radiation therapies, your white blood cell count does get affected. So your immune system is not as strong and potent to fight these acute insults. If that occurs and it continues through time, what happens is you get into a chronic inflammatory issue where the response time lingers. And over time, it may have a negative impact on your tissue and organs where you're not healing properly. And that could be, from a long-standing course of different kinds of medication, i.e. whether it be prednisone, whether it be chemotherapies or radiation therapies, or your white blood cell count has been low for a long period of time. Chronic inflammation is big. It's one of the fortes I practice, or I try to help treat patients, not just aside from oncology, but chronic inflammation can also, aside from oncology patients, if anyone has any kind of rheumatoid arthritis or any kind of fibromyalgias or myalgias, they can also be comorbidities. Diabetes can also be a comorbidity that can affect chronic inflammation. But chronic inflammation is not very abrupt. They're pretty much subtler, which can be very easy to overlook. Most of the time, again, the chronic inflammation is fatigue. There is fever that can create some issues. Sometimes there are actually mouth sores. So patients get confused whether it's a cancer sore, it's a herpes virus, but sometimes there are sores in the mouth. There are rashes that come across your body, whether they could be blotches. Abdominal pain sometimes is also correlated with chronic inflammation, and chest pain. Typically, usually, if I hear any of this, I refer them either to their oncologist or their primary care physician, and also sometimes dermatologists too, to help to see whether or not these skin lesions are acting up or if there's something to be of concern. And they can range from mild to severe. And again, chronic pain can last for months or years. So if we untreat it and not provide any kind of intervention, sort of like, let's say if you had an autoimmune disorder, the immune system is affected, and then basically, again, it attacks healthy tissue. That healthy tissue is not there to provide wellness and healthy tissue. And keep in mind that chronic inflammation does not affect everyone. In some cases, chronic inflammation, we don't really know the clear cause or underlying cause where it comes from. But however, some of the experts that have been doing a lot of this research say that some of this can be affected either by smoking, lack of exercise, obesity, increased alcohol consumption, and stress levels. Diet is huge. Diet is very big. I touch on it briefly with my patients. Actually, October, aside from celebrating Cancer Awareness Month, is also Physical Therapy Awareness Month. So each week, what I've been doing here in our clinic is providing patients with an anti-inflammatory diet, because there are chronic patients that come into our clinic here that have inflammatory conditions. And an anti-inflammatory diet is very good for a lot of patients, even patients with MS, oncology patients, and they didn't realize how much this can help, and how they provide antioxidants to the body, which are called polyphenols. These certain types of antioxidants actually create healing and prevent antibodies and increase oxygen into your body. Here are just some examples. Olive oil, leafy greens, kale, spinach, tomatoes, fatty fish, salmon, and sardines and mackerel. I know it might not be the most appetizing for some of you, but who doesn't like salmon? Nuts, sometimes you have to be careful with nuts, because whether or not there is an allergy to nuts, you have to, obviously, when I talk about diet, I touch on it briefly, but I definitely refer out to a dietitian who has experience working with oncology patients. and inflammation type patients where they can justify, because there are various different kinds of diets and chronic inflammatory diets, and not all of them may work for you. So it depends on other comorbidities that you may have or other allergies that you may have to certain foods. But if you're looking to rethink your eating habits, consider trying a Mediterranean diet. It's pretty safe across the board. And certain foods to avoid are carbohydrates, rice, white breads, pastries, red meats, processed meats like hot dogs and sausages and cured meats. But again, we all have our guilty pleasures. So once in a while, it's okay, everything in moderation. But again, I kind of refer out to the expert. So the bottom line is, I just tell patients, you can control what you can control. And if it's something that you have questions with or concerns with, you always want to ask the experts in all of this. And I encourage all of you to speak to your oncologist, to speak to your allied healthcare providers and ask them these questions. How exercise is one of the best anti-inflammatory steps that you can take, and diet. If you haven't had a conversation regarding diet or anti-inflammatory diet with your oncologist, I would stress to have that conversation and see how they can steer you in the right direction. And if you're struggling with balance and unsteadiness, you can improve that. So I'm going to show you really quickly a couple of things that we can do that I show my patients to do very quickly on how to improve and enhance their balance. So if you had a kitchen sink or vanity or something that you could hold on to, what I have my patients do, let's see if I can show you a little demonstration here, is I usually tell my patients to put their hands on a kitchen sink or vanity. I tell them to kind of lift. I'm sorry if you can't all see me. I'm trying my best. There we go.
Can you get rid of your PowerPoint maybe so we can see it? It's hard to see it with the PowerPoint.
How about now?
Perfect.
Good? All right. So kitchen sink, vanity, pretty much you place your hands on the kitchen sink and vanity, and I have my patients kind of lift one leg up off the ground like so, and the other opposite leg is bent, so you're balancing. So literally this leg, the leg that's balancing is bent. Okay, so your foot is on the ground, and then what I have my patients do is, as their leg is on the ground, I usually tell them to get in like a really good flamingo kind of stance where they can kind of mimic a flamingo. You tap. So as you're balancing, you want to tap on a surface so it allows you to prevent yourself from a fall, from a buckle of a knee, and you kind of balance yourself this way. And you tap about 10 times, and I tell patients to do about 6 on each side. Okay, so again, as you're tapping, you're balancing here, just like that. And you can alternate sides, okay? So that's one little quick strategy I have my patients use to help improve and restore their balance. And that's really quick and easy that they can do. Can you guys see the PowerPoint again? Can you guys see it? Okay. All right. Good. All right. So basically, when we treat balance strategies, what I try to teach my patients is decrease your dependence on your vision while you're maintaining your balance, because most of the times we're looking down to see where our feet are. So again, it'll be good if you can actually find a point where you can balance and then stare at a point and looking at the horizon, where you can actually hold yourself up. Sometimes you can use a corner of a room, which is fine. I'd rather have my patients who are not really secure with balancing, having their hands on a very stable surface so that they can prevent themselves from falling. You can use the back of a chair, and then you can increase your balance by increasing the different kinds of ways. You can tap with one hand, you can hold without holding. So there's a progression to your balance. You also want to be able to try to, when you're walking, to move out of your visual field. So basically what that means is you start slow, and you can increase your speed in terms of balancing. So with the tapping of, let's say we'll use the example of tapping hands. You kind of start slow, very slowly, so that you're actually having physical contact with the table, then releasing. And then you can increase it with speed, sort of like if you were playing piano and like you were playing like staccato type, and then you can go very rapidly, and then you can go without holding. So there are different progressions that you can get into. And the ankle and foot postural recovery strategies, what does that mean? Your ankle and feet will quiver and shake to help you prevent from falling. And that's a strategy that your body is designed to do. Sometimes your leg will quiver and sometimes your hip will quiver. But what we try to instill in patients is building up the confidence to quiet their foot, quiet their knee, so that the energy is dispersed throughout the entire leg. And it's practice, 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 practice. Is practicing with a skilled physical therapist. It's practicing with an exercise physiologist, a personal trainer, and making sure that that particular balance strategy, again, is individualized. There are many different balance strategies. I just showed you a very basic and simple one when I teach patients who are at risk for falling, who have a fear of falling, that I go and engage with. And if you have any information, questions, or concerns, you could reach me at my number here. I work at Ivy Rehab Physical Therapy. We're located in Brookfield, 3 Federal Road. And at all, any questions or concerns, you could always reach out to me. And really, thank you so much for having me on. It's been a treat.
Thank you so much, Nicholas. I really appreciate it. That was wonderful and very informative. I'm going to move along now because we have 2 more presenters we're going to try to fit in, and then a few Q&As. So our next presenter is Laurie Plaut, who is a lymphedema specialist. And Laurie graduated from the University of New Hampshire in 1992 with degrees in both psychology and occupational therapy. She began her lymphedema journey in 1999 with lots of advanced training and whatnot. And she has even attended several courses in the treatment of lymphedema at the Fielde Clinic in Germany. So Laurie has been a certified hand specialist since 2001 and a certified lymphedema therapist through the Lymphology Association of North America since 2002. So I want to welcome Laurie, and I will now spotlight her. There you go.
Oh,
Thank you, Laurie, so much for being with us today.
Thank you. That was a great talk, Nick. I just want to apologize in advance if you hear my dogs, because they are with me. And this is the first time I've had makeup on and no hair in a ponytail in 5 months. So thank you for that opportunity. I'm going to start. I can share my screen, I assume now. Is that...
Yes, you have permission to share.
Okay. Are you seeing that now?
I am not. You should be able to go down to the bottom and hit share under share screen. If you hit share screen, you should have the ability to.
Okay. Sorry.
If you have any problems, we have it as well and could put it up, but it'd be better coming from you if possible.
Yeah, I gotcha. Let's see. At the bottom.
So at the bottom of your screen, if
see.
you're on a laptop, you should have something that says share screen.
Got it.
There it goes.
Okay, great. Sorry about that. Okay.
We've all been there.
Okay, so this is a presentation I kind of tweaked. Some of you may have seen this, maybe not. But I'm going to talk about basically a very general presentation on lymphedema, what it is, the precautions, contraindications, and how we treat it. This is a picture of the lymphatic system, and we may or may not go back to this, but it is important to understand the basics of the lymphatic system to really understand what lymphedema is and why we tell so many people what to do or not to do, or precautions, which have actually changed a lot over the years. But essentially, the lymphatic system follows the circulatory system. And so the lymphatics are presented in green. And we'll kind of go back and forth to this slide maybe if needed, but it basically, the lymphatic system absorbs 10% of the fluid that is transferred from your arteries that go to your veins. Also the lymphatic fluid is considered as water, white blood cells, cellular debris, proteins, and fat. The important part about the proteins is that proteins are too large of a molecule to be absorbed by the veins. So that's absorbed by the lymphatic system, and that's what causes the fluid to be a thicker fluid. So when it gets, when you develop lymphedema, it becomes more fibrotic, it becomes thicker, and that's because of the proteins. The lymph vessels are a series of one-way channels that move the lymph fluid back to the circulatory system. There are capillaries that are the smallest that don't have any valves or and the fluid can move back and forth in any direction. From the capillaries, they go to what are called precollectors, which contain smooth muscle cells and valves. And the important part about that is that's what we utilize when we're doing the manual lymphatic drainage, which is the massage we do to stimulate the lymphatics. As well as the collectors have smooth muscle cells. And then the trunks are the larger lymphatics that drain fluid back to the circulatory system. So the movement of the lymphatics, like I talked about, it starts with your capillaries, moving to these collectors, the lymph nodes, which filter the lymphatic fluid. Then that moves to the trunks, and that goes to your lymphatic ducts back to the venous system. And the reason to understand this is, you know, a lot of people don't understand, like, why does lymphedema happen? And we're going to get into that a little bit more. I talked about the lymphangions, and again, the important part about the lymphangion is that smooth muscle cell. And so when we stretch the lymphangions during manual lymphatic drainage, it can increase the production of lymph fluid by about 10 times. Watersheds, I know this is kind of dry, and it's really hard to do a talk when you can't see people's faces and when to, like, you know, move on from a subject. So I apologize if some of this is really dry, because the one thing what's hard when you go to a course is they always talk about anatomy and physiology, and you just want to get to the meat of what you want to talk about. But to understand that, sometimes you do have to do some of this anatomy. And there's another picture about the watersheds. But the watersheds kind of divide the body in designated areas, and your lymph fluid drains is kind of draining to groups of lymph nodes within a certain watershed. Hopefully that'll make sense later. So these are some pictures. Here's my cursor. I was going to make it bigger, but so the watersheds are going to be your clavicular area, down the center of your body, across your waist, and the important part of that is when people develop breast lymphedema and they think that wearing a compression bra is going to help, what happens is it compresses right in through, right below the breast, and it doesn't allow fluid to move down into another area for absorption. So functions of the lymph nodes is they're a filtering station for bacteria, toxins, and debris. They produce white blood cells, regulate the concentration of protein in the lymph fluid. And each node serves a specific part of the body, which I didn't understand, but that's a part of the sentinel lymph node. When we talk about sentinel lymph node biopsies, so certain nodes, even as far as the hands go, like there might be a specific lymph node that helps to drain a specific part of your hand. And so sometimes you wonder, well, how come somebody gets lymphedema and their arm is large and their hand isn't so bad, or vice versa? And it depends on what lymph nodes are taken. And of course, we don't have any control of knowing that. So the definition of lymphedema is, and I was just looking at a little talk today at work, which I didn't get to finish, unfortunately. It was through the American Cancer Centers. And but typically what we say, it's an abnormal accumulation of a protein-rich fluid in the tissue due to an insufficiency of the lymphatic system. It's more commonly seen in the extremities, but may also occur in the face, neck, abdomen, and genital areas. And what this one doctor that was just talking about, it basically is what I described, but it's tissue swelling. And the important thing is to remember is that it occurs when the lymphatic load, so the amount of lymph fluid, exceeds the ability of the body to transport that fluid. And that can happen as a result of an insufficiency in the lymphatic system that you're born with, or which is primary lymphedema, or it can be secondary, which is what we're all here to talk about, is treatments from secondary to cancer treatments or a trauma. So primary lymphedema, quickly, as I mentioned, is a result of an insufficiency in the lymphatic system. So either the lymph vessels are absent in an extremity or an area. They might be too narrow, they might be too large, and they're just not working. It can be present at birth, so you can just be born with swelling, or it can develop later in life, which is called precox. And other certain genetic disorders can affect that. The secondary lymphedema is essentially, with treating breast cancer patients for most of my client population right now, is a lot of times a result of cancer treatments. So we know that there is a cause for the condition. Most common, so not related to cancer, the most common cause of secondary lymphedema worldwide is from a parasite that can go through the feet, walking around barefoot. It's a parasite, Phyllorysis, and it basically eats up all the lymphatics, and you may not even know about it until 20 years later, and your leg is huge, large lymphedema. But here in the United States, the most common cause of secondary lymphedema is from cancer therapy, such as lymph node dissection, radiation, surgery, scar tissue. And it only affects the region of the body where the lymph nodes have been removed or where the damage occurs. So when people develop swelling after chemotherapy, or they have swelling in one extremity, but it wasn't the one that was affected from surgery, I don't think that I've ever seen that in 20 years. Technically, I guess it could happen if you have a very, maybe like a primary lymphedema about to develop anyways from your own insufficiency or inadequate lymphatic system. But typically, you're only going to develop secondary lymphedema in the area that was affected. So here's another picture of lymph nodes. And so with breast cancer treatment, obviously, when the lymph nodes are affected in the axilla, you can develop swelling anywhere in this upper quadrant. Lymph nodes that are affected in your inguinal area or from gynecological cancer treatments is going to be below the waist, either one or both extremities. In head and neck lymphedema, with surgeries involving the head and neck, this is what's going to cause swelling in the face or neck. Risk factors for secondary lymphedema, lymph node dissection, radiation, obesity, and when does it occur? So the most common time that it occurs after breast cancer treatment would be within the first 3 years. It can occur at any time, which is really frustrating. So the risk reduction practices we talk about are lifelong, but it's most commonly going to happen within the first couple of years. So just a couple statistics. At 2 years after radiation, someone with an axillary lymph node dissection has a risk for developing lymphedema at 20%. Factor in radiation, that ups it a little bit. And as time goes on, the risk goes up. And that's my beautiful dog. A lot of people have seen Jenga. So precautions and contraindications, I throw those pictures in for questions, but we're not doing that now. It's very, very different times. Anyhow, so contraindications, these have changed over the years. We used to have something called the 18 steps to prevention. And, we really can't say that we can prevent lymphedema, but what we can do is help you reduce the risk for developing lymphedema. So the National Lymphedema Network is a wonderful resource, and they've kind of pared it down into talking about how to manage your skin and into categories as to, you know, rather than don't do this, don't do that. So maintaining good skin integrity. We talked about the lymph nodes filtering noxious debris and bacteria. So if you've had lymph nodes removed, you want to avoid any sort of cut, scrape, burn. Anything that damages your skin is a pathway for bacteria to get in. So the extremity that may have been affected by a lymph node dissection, or that you have lymphedema or at risk for getting lymphedema, you want to keep clean and be aware of keeping it moisturized in the winter, using bug spray, using suntan lotion. We also talk about no extreme temperatures, such as a hot tub or a sauna. And what that does is it increases circulation to the extremity. And in that very first picture I showed you, where you have the arteries and then the veins and then the lymphatics, if you increase the circulation, you're going to increase lymphatic flow, and it's just going to make it possibly set you up for developing lymphedema. I also say no heat to the affected side ever that's had lymph nodes removed, or where you've had radiation. It's just another risk factor for developing lymphedema. So if you know you've had any swelling, you don't want to ignore that. That's something to contact the doctor about immediately. We also recommend, or don't recommend, repetitive movements with resistance, vacuuming, scrubbing. That's not to say that people can't vacuum or scrub with the extremity that may have been involved, but you want to go back to activity levels that you had prior to treatment in a very slow, methodical manner, so that if you start to develop any symptoms of swelling or any issues, you can back off that level of activity. We want to maintain good circulation. So we say no blood pressure, avoid on the side that's affected, avoid wearing tight clothing or jewelry. And that can constrict the superficial lymphatics. Sorry, I'm kind of rushing, and so it's going quick. You also want to maintain an ideal body weight. The lymphatics can become kind of constricted by fat. So, you know, there's a nice balance of when you are maintaining a good, healthy lifestyle and you have less adipose tissue, those lymphatics are going to have less difficulty working and moving fluid along. You also want to avoid deep tissue massage to any area that's been affected or has a risk factor for developing lymphedema. You want to be aware of signs of infection. An infection can also lead to lymphedema because the body is creating an inflammatory response and bringing a ton of fluid to that area, and a lot of other biological factors. And once that you've had increase in swelling in an area that is at risk for developing lymphedema, that can kind of set you over the edge there. And we'll get into that a little bit more. And I'm talking about wearing good compression sleeve or garment if you do have lymphedema. Something I want to talk about that's super, super important are infections. And the signs and symptoms of infections are heat, redness, warmth, a feeling of malaise, like you feel like you have a flu, and fever. And especially with times right now, what is the most important thing to differentiate feeling sick versus having a cellulitis or an infection is you would see redness. And in winter, you know, if you feel crappy and I feel like you have a flu, just remember to check the extremity that may have been affected by surgery or lymph node dissection, because I've had people think they had the flu, went to bed, woke up the next day and had a bright red chest, arm. So I just like people to be aware that that's something really important. And if you do have any of those symptoms, it's night, you go to the emergency room immediately. A cellulitis can spread very quickly, in particular with people who've had radiation. But if you've had your lymph nodes removed, you just need to be aware of that. So some post-breast surgery considerations to help reduce your risk of developing lymphedema after breast surgery is we talk about not elevating the arm above 90 degrees for the first 2 weeks. And that helps to reduce a seroma, which is basically, it's kind of like a water balloon. It's like a pocket of fluid that develops from where they've removed either lymph nodes or tissue. It also helps to encourage lymphatic generation. And I know there's some doctors who feel it's okay to start raising your arm right away, but you're really not going to reduce, you're not really going to have, unless you have some other frozen shoulder or some other issue prior to surgery, it's not going to improve, cause your shoulder to get restricted if you just keep it to 90 degrees at 2 weeks, for 2 weeks. And then eventually, once after 2 weeks, you can start moving it normally. We also want to adhere to the risk reduction practices, which I went over some of them, but lymphnet.org is a wonderful resource. It's normal to have a centimeter or two of swelling the first 6 weeks to 8 weeks after surgery. It's after that that we start to get concerned if people are if that swelling hasn't resolved. And again, you can begin range of motion exercises beyond 90 degrees after 2 weeks. Some of the risk factors for developing lymphedema, we talked about this. I don't know why they say younger women, higher education. I think it's more people who are on top of things are going to get diagnosed earlier. They're not going to ignore their symptoms. So I think just being aware of the signs and symptoms of lymphedema is helpful. So the incidence of lymphedema is based on how it's defined. And so that's why it's hard to say who gets how many, what's my risk for developing lymphedema? It depends on how we define it. So if you do it based on self-report, like I feel like my arm is kind of swollen, you know, 43% of the, there's a 43% incidence. If we use 10% limb volume, and what that means is you can either take measurements every 4 centimeters of the extremity and calculate the volume. And if there's a difference of 10%, then that's considered lymphedema. We also used to use a volume meter, which I don't think anybody uses it anymore. It's just using, putting the arm or leg in a big tube of water, and then the water displacement tells you how much, you know, you can calculate the volume change from that. But technically, you know, typically we use these every 4 centimeter measurements. And another criteria is if there's greater than a 2 centimeter circumferential change from when we do measurements. So with a sentinel lymph node biopsy, there's still a risk of developing lymphedema. And I've actually seen a little bit more, I would say, of breast lymphedema and breast swelling with people who've had sentinel node biopsies and radiation. I mean, it's still a lower risk, but it's still something, we can't just assume just because you had a sentinel lymph node that you're not going to get lymphedema. So you have to be somewhat adherent to some of these precautions, maybe not as strict, but at least somewhat. And then with pelvic lymph node dissection, 18% is the incidence, or if you've had 10 or more lymph nodes removed. Head and neck lymphedema is something else we can talk about, and I know I'm probably getting short on time, so I want to talk about signs and symptoms. Usually it's a slow onset of symptoms. It might be preceded by a trauma, such as a burn or infection, or I've had people say I was packing up my house for the year, for moving or putting summer clothes away and swapping out winter clothes. And so doing something out of the ordinary, which caused a lot of stress to the arm, can cause you to develop lymphedema, and it would be like a very slow bit of swelling. And sometimes people don't even really realize that they have swelling. They think they haven't had it, but it might be slowly creeping up, maybe over the winter, you're not wearing short sleeves or you're wearing, sweaters, you don't notice anything until springtime or summer. One of the very subtle characteristics of lymphedema in the very, very early signs is a decreased appearance of your veins, tendons, and skin contours. So if you were to look at one arm versus the other and start to see less visibility of the veins, less creping of your tissue, less prominence of your tendons, you can still have the same size circumference, but these symptoms are, I don't care if there's no change in volume or change in circumference, but if I see this, I'm going to treat somebody for lymphedema. In the beginning, we can also have pitting edema, which is when you indent, you push your finger on the tissue, it'll kind of stay there. You can read through a lot of this stuff. Stages of lymphedema, stage 0 is a latency stage, and that's basically anybody who is at risk for developing lymphedema. And this is when you might have some, what we call subjective complaints, like a feeling of fullness, a feeling of heaviness. And that's when I'm going to listen to somebody and say, hey, let's get them into a compression garment. Stage 1 is called reversible. And what that means is that you're starting to build, the tissue is starting to fill up with fluid. It might be pitting edema, but it's reversible. So if you elevate the arm or the leg, it goes away. What happens in stage 2, and it's called spontaneously irreversible. And what that means is that protein-rich fluid has been stuck and hanging out for a long time, and it just at some point doesn't go away with elevation. So addressing the lymphedema in that very first 2 stages, stage 0 and stage 1, is important. So if we can avoid getting people to this point of stage 2 or stage 3, which there are even more skin changes, that's when I like to see people so they don't have to do all of the treatment that we do for lymphedema, which you'll understand why when we get to that. So there's also a classification system of lymphedema, which is, we talked a little bit about it earlier, but depending on your training, you can, some people are categorized as having lymphedema earlier than others. So here's a stage 2 lymphedema of somebody who had 19 lymph nodes removed. I considered it moderate on the right-hand side. And this is somebody who only had 9 lymph nodes removed and had quite a bit more of a severe case of lymphedema that was, harder to manage. This is a leg lymphedema. This I would consider probably primary lymphedema. It looks a little bit more just the shape of it. I guess it could have been a secondary lymphedema, but this is something that's been brewing for a long time. This is some head and neck lymphedema. And that's my daughter dog. So how do we manage lymphedema? Early on, a lot of times people say, can't you just drain it? You can't, because the fluid is in between, in the interstitial space between the skin and the muscle. It's not a fluid that you can just go in and drain. And if you did drain it, it would just come back. It's part of a system. And so the body is always circulating a certain amount of lymph fluid. So if somehow you draw it out, either with medication or you were to try to drain it, it would just come back. It's a balance of the protein and of the pressure. So, and that can kind of get confusing, but what we do know, and the gold standard for lymphedema treatment, is complete decongestive therapy, which I'll go into. There are some more surgical options that they're talking about as far as lymph node transplants, but that's another topic, a topic for another day. So what is complete decongestive therapy? So this is therapy that I do when people either have more than 2 to 3 centimeters of swelling throughout their entire extremity, and or if they have a very thick edema. If you just have a couple spots that are swollen, I probably would put somebody into a garment. But if somebody has that either 200 millimeters of volume difference or 10% difference in volume size, I'm going to do this kind of treatment. And it involves the massage, about 45 minutes of massage, using what we call short stretch bandages. So we massage somebody, stimulate the lymphatic system to get that lymph fluid moving. We bandage it, which doesn't allow the fluid to fill back in. We teach people about skincare, some basic exercises to get them moving. And we try to do it 5 days a week if we can. And the goal is to reduce the size of the limb or extremity, head and neck, wherever, back to as small as we think we can get it. And then we have to give somebody compression garments for day and night, depending on how extreme the lymphedema is. The bandaging also helps to improve the skin integrity, to soften the tissue. And the important thing to remember is that this is a lifelong management. There is no cure for lymphedema, unfortunately, but we can learn how to manage it. And again, this is why I really like to get people into therapy, get them into compression garments, get them educated on the risk reduction strategies so that they don't end up having to do this program. And unfortunately, I'm still seeing people that need this, but you know, sometimes you just, no matter what you do, it's going to end up being enough swelling that you have to manage it this way. So the massage technique was developed by Dr. Vader. It's a special techniques and special pathways that we follow to get that fluid out of the extremity. And then we also want to do certain techniques to help break down scar tissue if necessary. Then we do some bandaging, and as I said, they're short stretch bandages. So ACE bandages are not going to work for lymphedema. ACE bandages have what we call a very long stretch, and they work. ACE bandages work when you're at rest, and short stretch bandages for lymphedema work when the patient is, or when the person is using their arm and using the muscle activation to help stimulate that. People keep their bandages on for 23 hours a day. And then they come in, they take them off, take a shower, come in, and then we start it all up again. It uses and improves the efficiency of the muscles and the joint pumps, helps to prevent reaccumulation of the fluid, helps to break down scar tissue. I usually teach patients how to do their own bandaging or teach a family member. And this is an example of an arm that was bandaged, and yes, the fingers are always included. This is for a leg, which it's challenging with legs because you have to be able to walk and you have to get the right kind of shoe and footwear so that you're, you know, safe with ambulating. And then we teach people some basic exercises in the bandages to help with that muscle activation. We talk about skincare, and as I talked about earlier, you're more at risk for developing infections. So you just want to be careful about that. We manage lymphedema after complete decongestive therapy with compression garments, and people need to replace their compression sleeves every 6 months, or have 2 sets, and that'll last you about a year. But I see people who come back after 7 years who have the same garment. It's not going to help you. You have to replace those garments every 6 months, or, you know, with 2 sets once a year. The nighttime garments that are usually Velcro or puffier garments, those probably last more than a year or 2. And unfortunately, they're very expensive and Medicare does not cover the cost of them. So it's really a challenge trying to find a balance between a garment that's going to work and one that can be affordable. So here's some other, in addition to compression garments, here are some other techniques that we use to help with compression. Some kinesio taping, this is for head and neck, obviously. These are some other, the tribute is something that I use, which is this big thing. And then Jovi Pack is this type. This is for head and neck. You know, you have your leg and your arm. These are something for nighttime. And these are compression bras that I recommend often for people who have breast swelling, even if it's not even considered radiation. I mean, considered lymphedema. People with radiation, one of the lasting effects can be some mild inflammation, and it's better to get into compression, I would say, before you do that follow-up with radiation oncology. Once the tissue is able to tolerate regular clothing, and if there is some swelling, a compression bra may help to get some of that breast swelling under control, or at least help manage it earlier on. I tried to do that in under 25 minutes. I'm sorry, Kate. And that was probably way too much information for a
no apologies whatsoever. Those were both wonderful. And again, we probably could have made a presentation with just one of you. And we did fit a lot in. So please, no apologies. It was wonderful. Thank you. So our last presenter, who's just going to really talk quickly, is our own Alison DiPinto, who many of you may know her from Ann's Place. Alison is a master's level psychotherapist who's been in practice for over 26 years, and she's got special interests in movement and yoga. Alison was trained as the Healthy Steps instructor, which used to be called the Lead Bed Method, in 2006. And she's been the Healthy Steps instructor at Ann's Place for the last 14 years. This past month, we were lucky enough that Alison was hired as another therapist here at Ann's Place. So we're really lucky to have her as part of our team. She's been a lifelong dancer and knows firsthand both the physical and psychological benefits of exercise and movement. And she's really grateful to be with us to share with you today. So I'm going to spotlight her quickly. She's going to talk to you a little bit about a program we run that helps with lymphedema and other movement things. So thank you, Alison.
Okay. Hi, can you hear me? Okay, great. All right, so really quick. So Healthy Steps was developed by a woman named Sherry Lebet Davis in 1980. It was called the Lebet, she originally called it Focus on Healing, the Lebet Method. She is a professional dancer, and her two brothers are physicians. And her mother was diagnosed in 1980 with breast cancer. And so they got together and they were like, we need to develop a program that will help her, heal and thrive. And so that's just what they did with the Healthy Steps program. It's movement based. It's it's set to music. It's got 6 routines. And then Sherry herself was diagnosed with breast cancer in 1996, and then in 1999 developed lymphedema. And so she and her brother, Dr. Mark Lebed, got together and decided that they were going to create a warm-up that would address and hopefully help with the symptoms of lymphedema. So I was going to give you a little demo of that, but that's okay. If anybody has any questions, there's a website called gohealthysteps.com, and there's video, and there's the history, and there's the evidence-based research of how this does promote strength, can help with symptoms of lymphedema, flexibility, balance issues, overall well-being, psychological well-being. So it's a lovely program. We get together on Thursdays at noon. If anyone is interested, you can certainly email me at allison@annsplace.org, and I can tell you all about it. But we have something right in our little group that addresses everything that Nick and that Laurie had talked about. So again, any questions, please feel free to contact me.
Thank you so much, Alison. I'm sorry we didn't have time. There's so much,
That's
as I
okay.
said, so much good information. But I would highly recommend anyone who's interested in checking out Alison's Thursday class. You can register by contacting her or anyone at Ann's Place. They can get you registered. That being said, we've got a couple questions, and Nicholas had to go, but I have an answer from him for the one that was asked. And then if anyone else has a question, you can unmute yourself for Laurie, or if you have a question for Nicholas, you can let me know or Daisy know, and we will get the answer and get back to you. So I'll start with the questions that we had first. And the first one from Nicholas, Barbara asked, no, it wasn't Barbara. Hang on a second. I've got to find it here. I wrote it down so I'd have it. Let's see, where did I put it? Yes, Barbara asked, what is your view on icing hands and feet during chemo? Does this help prevent neuropathy? And Nicholas's answer was, ice is nice and is okay for pain. Heat can increase circulation to the body and may assist with increasing circulation and sensation. So I hope that answers your question. And again, if you have any other questions for Nicholas, you can email me at kate@ansplace.org. And I will get the answer for you and get back to you. Laurie,
Hi.
there's one question for you.
Oh,
And
sure.
then if there are any others that come up, people can unmute themselves and ask. And the question comes from Frances, and she wanted to know, does the swelling resolve at night?
This swelling can resolve in the very early stages of lymphedema. At night or during the day, it can resolve with elevation. At some point, it doesn't resolve on your own. The one question I wanted to answer, the question about Barbara's question about, well, it's
Oh,
not even
sure,
cancer.
please, about the vuonicin.
I know that they talk about with the chemo cap, the cold chemo cap, so maybe that's where she's thinking that from. I don't know, and I think we should I can look into it and maybe get back to you about, I've never heard of that, but it's an interesting thought. So I'll try to do some research and come up with a better answer for Barbara.
I appreciate that. Thank you. Do we have any other questions from anybody? Let me
Yes.
spotlight.
Yes, can you hear me?
Yeah.
Okay. So Laurie, is there another reason why there could be swelling? I'm on a chemotherapy regimen right now. I just finished the 3rd round out of 6.
Yeah.
And they added a drug to my 2nd round. And I noticed that after both the 2nd and 3rd round, I was getting swelling in my calves and ankles, as much as I think almost an inch around my calves. It subsided. It's more like a half an inch, I think, but it's hard to, figure it out. But it came on, a day or 2 after the treatment. And then last time it subsided. And then right before the next treatment, so it was almost 3 weeks later, it started to swell back, again a little bit. And I started drinking a lot of water, and I noticed that it went down from that. I don't know if that was coincidental or not, but I guess my question is there hopefully a reason for swelling that's other than lymphedema that could be connected to the chemotherapy?
Absolutely. Absolutely.
Okay.
And oftentimes, and I don't know what your chemo is for, but a lot of these drugs that I've seen, Herceptin, Perjeta.
I'm taking the Herceptin, a biosimilar to Herceptin.
Yeah, and I don't know how if it's affecting the heart or what system it's affecting, but I've seen it. The only concern is, because I like to be proactive, is if there is an extremity that you have that's at risk for developing lymphedema, it might not be a bad idea to have some type of compression to wear when you're getting the swelling so that it doesn't get worse. But
Okay.
Certainly that's something to talk about with your oncologist, or and it may just be I don't have a concern when it's bilateral and it's and sometimes people get swelling like all over, like their hands and their legs. But again, if there was an extremity that might have been at risk for lymphedema with respect to lymph nodes being removed, maybe you want to have a conversation with your doctor about getting compression garment just to wear when you know that you're having that symptom. But it should resolve. But it may take like a long time after chemo for that totally to resolve.
Oh.
It's totally common. I mean, I see it a lot.
Okay. Can I ask another question, or?
I feel like I didn't present the way I wanted to present. It's so hard. Now I can see you. People when you're talking, like, I don't know what I'm talking about.
No, it's very helpful. Thank you. So I think you had mentioned, or maybe others had mentioned, Nicholas mentioned the reduction in white blood cell count, which probably anybody going through chemo it has experienced, and definitely that's like a huge factor for me. They almost didn't allow me to do chemo this past time. So I'm kind of trying to figure out what can I eat or what can boost that. I know that they give you Neulasta, but I've heard that isn't fun. So what, is there
Yeah.
anything you could recommend to eat or sleep or what? I'm sure sleep is a good thing, but anything in particular that could help to bring the white blood cell count up naturally?
I'm not aware of anything. What I've heard people recommend with the Neuropathy or those type of medications is to take a Claritin before that to make it less. People who are younger have a harder time with that Neuropathy shot because it helps to boost the bone marrow. And then from the way Dr. Rella explained it to me when my father went through chemo, when you're older, you have less bone marrow. So when it swells up, it's not quite it doesn't affect older people in general as much as it does younger people.
Oh, I see. Okay.
So that's why people get those bone aches and pains. But I don't know if you're in the Danbury area, but we have Peggy O'Shea or Peggy Gilmore, who's like an alternative nurse. And other cancer centers should have some type of alternative person that you could maybe meet with to make recommendations for. I think she recommended like a bone marrow soup to somebody once, but I think that was more for red blood cells. But at least look for complementary medicine within the cancer center that you're going to and see if they have somebody that you can meet with to make some recommendations.
Okay, terrific. Thank you.
Yeah.
Oh,
I have a question for, I'm sorry. Does
okay.
someone else want to go?
No, Gwen, go ahead.
Thank you. Hi, Laurie. I'm Gwen.
Hi. Let me find your
just-
face.
There, I'm
Where?
waving.
Oh, there you are.
Can
Hi.
you see me? Okay. Hi. I have lymphedema.
Okay.
And a seroma and the whole 9 yards in my inner thigh. My question that I have is, it's frustrating for me, and I'm wondering the fluctuation that I'm finding. So I wear a compression, I wear a swell spot, I'm doing all that and self-manipulation, but it still varies. There's variation, and I'm wondering what's causing that. Is that in relationship to over-exercising, eating, or is that just the nature of lymphedema, that sometimes it's better and sometimes it's worse?
Yeah, I think those are all good questions. Increased activity is definitely going to aggravate lymphedema, even if you're wearing compression garments. So you have to find that balance. With a leg, I think swimming, walking in water, like exercise is good in a balanced kind of way. But even we like people, I think swimming is a great exercise when you can get to a pool or something. I don't know if that's accessible to you or not. Even just walking in water is a good thing because it's a natural gradient of pressure. For every and I usually recommend this to people who are traveling. If you notice a problem with traveling, oh my God, there's so many things I didn't talk about in this talk. I'm so sorry. But it's a natural gradient of pressure. So every foot that you go down in a pool is another 25 millimeters of mercury. So it's a natural gradient of pressure. A seroma, I'm surprised you're still having an issue with a seroma unless it's a relatively acute thing that, your surgery was recent. Unless it's more of like some scar tissue that's thicker or more annoyed by the increase in fluid. If you've been walking a lot, I mean, the problem with legs and lymphedema is, if you're on your feet a lot, it's just gravity is just going to continue to pull some of that fluid down. So you don't necessarily, I'm not saying that you have to go elevate your leg, because if you're using compression, that should do it. But if you've been really active, you may need to get off your feet and rest a little bit.
Okay. So it's sort of that hard because everyone says you should be active and you should walk and you should do it, right? So
but then you need
that
to rest.
fine line. Okay. Okay.
There are compression pumps that are helpful, not the traditional compression pump, but the FlexiTouch by Tactile Medical is a pump that, and I can send this to Kate.
Okay, thank
It's
you.
a pump that mimics the massage that we do. It's not generally covered by Medicare, but if you've been using compression consistently for 4 weeks and you've been doing all the things you're supposed to be doing and you still have an issue, then it might be covered. And And what's important about this compression pump compared to the regular ones is it addresses the proximal area. When we do lymphatic drainage, you always start proximally. So we start with the abdominal area and then we work our way to the extremities. It's so hard because you can't even see you can't see me, but you start abdominally if you have, and then we go to the neck and then we do massage either with the arm or to the legs. So this compression pump mimics that, and it's a very gentle pressure. So
Cool.
not that I
Okay,
don't want
thank
to
you.
see people, but it's helpful.
Thank you. I'll touch base then with Katie to get that information. Thank
I will
you.
get it to you as soon as I've got it from Laurie. Gwen, thank you.
Great, thanks.
Any other questions?
I have plenty of time because I thought this was 3 to 4:30. So thankfully, Nicholas spoke first. So if anybody needs me to talk about something else, I'm happy to talk.
I have a question,
What?
Laurie. Can you
Yeah.
hear me?
Yeah,
Can you hear me?
yeah.
Okay. So is swelling the only clue you would get to that would indicate that you have lymphedema
Nope. So a
and
feeling of-
redness?
redness is generally not, redness is more a sign of an infection.
Okay.
If you had a really, like a really significant lymphedema or lymphedema in the breast, that would be maybe some redness initially, but in general, in the beginning, the first typical signs of lymphedema are a feeling of fullness, heaviness, the arm may not feel right, or the leg may not feel right. Can you tell I treat mostly breast cancer now, but it's the same for the leg. Even just noticing that your clothing is feeling tight, feeling a little bit differently, not being able to see your veins, you know, on one side versus the other, like the creping, your wrinkles might be less, your veins might not be as visible. Those are signs when your arm or leg is looking different than the other side. That would be an indication of some of
What about just pain? If all of a sudden, because you didn't make my day when you said it can occur up to 3 years. My surgery was about, it'll be 2 years, I guess, when I had surgery. But so that didn't make my day at all. But I'm all of a sudden now, I have pain still on the left side because I had 5 fog brain too.
lymph nodes.
They removed 5 lymph nodes.
Lymph nodes.
Yeah, they removed 5 lymph nodes, and so there's tenderness there. I was told it would take about 2 years. I'm getting to the 2-year marker. Now I have additional pain that's sort of going around the side into my back. And that's why I'm thinking, I don't know what that is. I haven't called the doctors yet about it, but so sleeping, it interferes with sleeping and all that. It interferes with lifting, moving, certain movements I make. That's why I was asking about the lymphedema, if it's just swelling or if it can occur under the skin in a sense and be in the muscle or whatever.
Pain isn't typically a sign of lymphedema. Pain is, you know, there could be an orthopedic thing that happened. You know, there might be something orthopedic going on. So, you know, depending on the type of surgery that you had, you may want to go back to, well, I get a lot of referrals for people who go back to their doctor years, you know, a year or 2 years later with pain or something weird, like something, it's not lymphedema. Sometimes it needs to be addressed by an orthopedic doctor, but typically lymphedema does not cause pain. Fullness and heaviness, yes, but not pain. A lot of times people, and one of the things I'm going to work on with Joanne Ballerini is coming up with an exercise program for people who don't necessarily need to see me. Dr. Stardub always referred people who were going to have a lymph node dissection. So I automatically would see people 3 or 4 weeks after their surgery to do the education and then kind of follow people if they were having radiation so I could educate them. But a lot of times I don't see people who've only had a couple lymph nodes removed or who didn't have any lymph nodes removed, but maybe a year or 2 later, they're still having some pain. They have pain in their chest. If you think about radiation, if you've had radiation, It's going to affect your pectoralis muscle. It's going to affect back here because of where it exits. So doing stretching throughout radiation and afterwards is so important. It's just something I tell people, you need to stretch indefinitely, because that radiation, it causes scar tissue, and scar tissue is always going to want to kind of be a little bit, it's not as pliable. It's never going to be as flexible as regular tissue. So just basic stretching exercises are so important to continue to do. So I'm hoping to get more of a protocol set for people. Does that help? Not really. That didn't help at all.
What do you mean by it could be an orthopedic problem?
So a lot of people some people might have a rotator cuff tear, or they might have a tendonitis in the shoulder, or they might, years later, if there's pain, it could just be something as simple as something orthopedic, or a muscular problem, something not related to the cancer. I mean, one thing I do want to go over, since I have you all here, is if somebody were to develop pain and swelling and redness, but not necessarily feels like an infection, but people who I get referred later on that have had, that never had swelling, and you're like 3 years later, 5 years later, that's definitely something to go back to the doctor for. You have to rule out a blood clot. You have to rule out any new diagnosis. That's when I'm more concerned about pain. But I'm not what you're describing is not what I'm thinking. I just wanted to make sure that people, if you have a lot of swelling and pain, that's like, go to the doctor.
Thank you.
Mm-hmm.
Any other questions while we still have Laurie with us?
If it's okay, it's Gwen Goldman again. Hi, I have one more question, Laurie.
Yeah.
Can you speak about taping, and if there's any downside of it? I mean, can you cause problems by taping?
Kinesiotaping? What kind of taping?
Yes.
Yeah. So the only concern about
kinesiotaping.
Yeah, I think kinesiotaping is great. I use it with that one slide with the head and neck. I think it helps.
Yeah.
It can help a lot. You just have to be careful of the tissue, because I find personally, after a while, the tissue, your skin can break down a little bit or be irritated. So you don't want to leave it on for more than a couple of days. And you do need to give your skin a break, because if you that's a pathway for bacteria to get into your skin if you have any, scabs or irritation from it. Or when you do put the tape on, go to a different area.
Okay, great. Thank you.
You're welcome.
Anyone else?
Laurie, I know you had statistics up, but I don't think I registered with me, but so lymphedema could come about even if it was just a sentinel node removal?
6%, I think, is the risk.
Okay.
So they do say it's okay now to do like a blood pressure or a blood draw on someone with a sentinel node. And a one-time thing I wouldn't be worried about. It's, if you, I probably wouldn't want somebody to have a blood pressure like you're in the emergency room and every 15 minutes they're like pumping it up. That probably,
Oh, okay. Yeah, that was actually, thanks for reminding me. I had a question about that when you had a list of things, no blood pressure, no blood. We're getting blood draws all the time. Mm-hmm. What are you referring to?
On the extremity. On that same side extremity where you had lymph nodes removed, you wouldn't want to have blood pressure because it's constricting the tissue. And the blood draws, they just want, it's more of inflammation from the blood. But they're now saying with just a sentinel node, it's not necessarily as much of a risk factor as we used to think.
Okay.
And how long should we not do it on the side that we had the cancer?
Indefinitely.
Oh, indefinitely. I didn't know that.
Mm-hmm. All of the risk reduction strategies are indefinite. I'll send Kate, I have a packet of information if you guys are interested that I usually give to all of my patients when I meet them. If you want, I can send that to Kate. And it's a little bit more breast cancer focused. I tried to make this talk general, but I'm also happy to come do a support group to just breast cancer people or head and neck or whatever.
I had my lymphedema 20 years ago, and they still choose not to do blood pressure or blood draws or anything out of the arm. And I have a very hard time drawing blood. They can only take it out of the top of my right hand. Seriously, that is it. And once or twice I said, look, use this other hand. I don't care. After a half hour, you know, just take the damn blood. But it's been 20 years and they still choose not to do it. You know, the Chinese do acupuncture and do everything with that arm, but we choose not to do that here. So I just want you to know it's been that long for me and they still choose not to. And I remind them then, you know, if it's a new person with blood pressure, I say, yeah, or you don't even remind them. I just say, use this arm instead of that arm. And it's fine.
Hello?
Laurie, quick question too.
Yeah.
If our lymph nodes play such a role in our bodies, when they remove, I think for me they remove 5 or 7, can't really remember. I want to say it's 5. Then what? How is our body, you know, how is the fluid moving around our body? And I like that, I don't know. Did you cover that? Did I miss it?
No, I didn't cover it because I talked about way too many things. But
No,
nothing very
it was
specific.
perfect.
So we have between 8 and 50 lymph nodes in our axilla, in your armpit. So when they do a sentinel node biopsy, they're just injecting the tumor with a dye or with the radioisotope or whatever. And the first lymph nodes that dye or radioactive isotope goes to are considered the sentinel lymph nodes. So oftentimes, sometimes when they go in thinking they're just going to go in for 1 or 2 or a couple, whichever ones might light up, as they say, they're going to take. And so, or they may have chosen to do an axillary node dissection on you and there were only 5 lymph nodes. So when they go in to do the axillary node dissection, which is the first and second level of lymph nodes, they go in and they just kind of scoop out a pocket of tissue, and whatever's in that sampling is considered your axillary lymph nodes, and it could be between 8 and 50, or maybe 5, or if it's considered, if you have 5 or more or greater than 5, it's considered an axillary node dissection. But you have hundreds and hundreds of lymph nodes in your body. You know, you have lymph nodes in your inguinal area. You have a lot of lymph nodes in your neck. Then you have a lot of lymph nodes on the other side. So as far as your lymph system goes and your your immunity, that's not going to be affected necessarily by those lymph nodes. Just that area. So being careful about your skin and making sure you try not to get an infection if you can, or being aware of keeping your skin clean and protected is helpful. Does that answer your question?
Yes, it does. Thank you.
You're welcome.
Hello?
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 The person on the phone has a question.
Oh,
Sure. Thank you.
Because I can't see her, so.
I'm sorry. I had a question. I'm not clear what a sentinel node is.
The sentinel lymph node is theoretically if a cancer was going to metastasize. So if the tumor had sent, it's the first node that if cancer was going to go to, it would go to that node. And so that's why when they inject, and they also do sentinel lymph node sampling for melanomas. So I didn't even talk about that on this case, but people who've had node dissection because of melanoma surgery also have the same risk factors, and it's the same. They just don't get radiation. So it's the first lymph node or group of lymph nodes that dye or radioactive isotope would go to, And then theoretically, if you were going to have if cancer had already spread, that lymph node would be positive. And then you sample that.
It would be the first to be attacked.
Yes. Does that help?
Yeah, I think so. So it's not just the one lymph node, it's the group of lymph nodes that it's attached to?
It's the first lymph node or lymph nodes that light up when they inject a tumor with the dye or the radioactive.
So it's not any specific one, it's whichever one is first.
Correct.
Okay.
Right. Sometimes it might be a lymph node in the breast, I think. And then sometimes it might be closer to the axilla. That's a very good question for your surgeon. It would answer much better, but.
What's the axilla?
The axilla is in right here, this area.
I can't see you. I'm on the phone.
Oh gosh, I'm so sorry. Underneath your armpit. That's your axilla. Is the armpit.
Okay, great. Thank you.
Yeah. Sorry about that.
No problem. Thank you. Thank you very much. That helped.
You're welcome.
All right. Well, hang on one second. Let me.
I have a technical question, Kate. I see
Sure.
that it's being recorded. So if someone wanted to listen to this who missed the beginning or something, how would you do that?
So Jean, to answer that, what we're going to do, and you shouldn't be able to have your, anyway. So what's going to happen is after we do after this is all done, Daisy and I will receive the recordings. And then the reason I spotlighted everybody is so that we didn't record any of the participants, because obviously for privacy purposes and HIPAA purposes, we can't share it with anybody if anyone else is seen. So that being said, once we've checked it and made sure it's all good, we will either share it on our website or we'll let people know either on a YouTube channel, our website, or to those that are interested in receiving it. So there will be a way to do it as long as it's good HIPAA wise. But yes, there were people who couldn't attend, and obviously we want to give this information to as many people as possible. So that being said, I am going to, let's see, go back. I can't seem to get, oh, there I go. Okay. So I just want to thank everybody so much for joining us today. These are all crazy times, as we're all aware. And Ann's Place is really trying to the best of our ability to bring you information in virtually, since we can't meet in person right now. And we're just so grateful to Nicholas and to Laurie and to Alison for sharing their time and experience with us. And if you have any questions that didn't get answered today, or if you are one of those people that wanted the packet that Laurie talked about specific to breast cancer, you can email me at kate@annsplace.org and I will get that information to you. We will continue as we can, as we're moving forward with all of our programming. We will continue to try to bring you speaker series from experts in the field. If you have anything specific you'd like to learn more about, please let us know. And again, we are just so lucky to have experts in the field willing to share their time and knowledge with us. So we thank you, Laurie and Alison, who I think is still on. Thank you both so much. And Nicholas, who had to leave us. So, and thank you to all of our Ann's Place people for joining us today and for bearing with any technical issues we may or may not have had. And as I said, just let us know if you have any questions or concerns. And we look forward to working with you virtually until we can see you again in person. So with that, thank you all so much and enjoy the rest of your day.